I want to thank everybody for participating in this webinar. My name is Dr. Tom Cheezum. I'm an OD and also certified professional coder and certified ophthalmology professional coder. When I saw what was happening to the practices of most of my colleagues around the country, where they're being required to close for routine care, I knew that that would be devastating to the financial stability of most practices. So the only alternative most of you have, other than emergency visits that must be seen in the office, is to learn how to do telemedicine visits for patients. So this webinar is to be used to help you to learn how to do that properly, both from a record keeping standpoint and from a billing and coding standpoint. I have no disclosures other than that I am the sole owner of Tidewater Optometry Consulting Services. Copyrights, CPT is a copyright of the American Medical Association, and ICD-10 is a copyright of the World Health Organization. Disclaimer is that when I put this course together, the information is correct. However, due to frequent updates that are occurring, especially during this national emergency time, there are lots of things that are changing every day. So before utilizing this information for billing and coding, you might want to double check on a couple of things. But as of the time this is presented, everything is accurate and up to date. Some caveats for everybody. The codes discussed here are approved by CMS for payment of services which are billed to Medicare and Medicaid. Payment for these codes is not necessarily approved by all private insurance carriers or for vision care plans, which may offer a primary care service plan. Also, certain state optometry regulations may prohibit certain telemedicine services by OD, so you need to check on that. With this stuff out of the way, let's get started, and let's start by going through some definitions. Telehealth refers to remote non-clinical services such as provider training, administrative meetings, and continuing education courses such as this one, in addition to clinical services. So telehealth refers to a broad range of services that may be done through remote communication. Telemedicine, however, refers only to remote clinical/patient care services. So you need to understand the difference between those two. Now, how do we communicate with patients through these telemedicine services and for coding of these services? First of all, there's what's called asynchronous telemedicine, or some refer to it as store and forward, where basically somebody sends you something or you send something to a specialist. The information is analyzed that provider offline, and then after reviewing that information, the provider gets back to either the patient or to perhaps another provider. The benefits of asynchronous communication are that in areas where there may not be easy access to specialty care, for patients and living in those remote areas, they can communicate with medical specialists if need be. The store and forward aspect of it may help overcome some language barriers that there may be between the provider and the patient themselves. So some examples of the asynchronous communication would be if a patient were to send you a photo of their eye through an email or a text message, or perhaps if you send some x-rays or scans to another provider for analysis, or if perhaps an OD were to send a picture of a patient's retina to a retinal specialist for consultation. The other communication method used for telemedicine is called synchronous communication. And these are live, real-time interactive video conferences with patients. So you have a two-way audio-visual link between the patient and the doctor. And there's some benefits to this. First of all, you're allowing a real-time ability to acquire details from the patient, perhaps pictures from the patient. You can ask the patient to take pictures of various areas of the face around the eyes or of the eyes themselves and show them to you. A lot of times the synchronous communication also allows a diagnosis and treatment plan to develop right during that session. And then also this face-to-face nature of the consult helps maintain the doctor-patient relationship. It's a lot more personal type of communication than what you may find otherwise. Now, there's some common elements for all of the telemedicine code sets, and we're going to be discussing 4 code sets today, or 3 code sets that refer to doctor-patient communication and 1 for doctor-to-doctor communication. Among the code sets that refer to just patient and doctor communication, there's things that apply to every single one of those code sets. First of all, the visit or request for these services must be generated by the patient. However, you can make the patients aware of the availability of these telemedicine services from your office. So, as an example, right now, if you have a comprehensive email list of all your patients, you may want to do an email blast to all of your patients to let them know that in this time of limited availability of office hours, that you may be able to deal with their eye care problems through a telemedicine visit. The next thing is that once you communicate with the patient has to give you verbal consent for the session in order for you to bill for the service. And also the service must be documented in the patient's medical record, just like any other patient visit that you would have. Under normal circumstances, telemedicine visits may only be used for established patients. However, right now, CMS and the Office of Inspector General have issued an exception to this, and it may be used for new patients as well. I would be careful with that, but it is available to you if need be. Also, normally the communication with patients should be done through a HIPAA-compliant platform, such as iCare Live or Voom for healthcare. Again, there's an exception right now, which is caused by the new regulations put in place on an emergency basis that allows you to use non-HIPAA compliant platforms. And we'll discuss those a little bit more in a couple of minutes. Some other common elements among all of these is that the consult for the telemedicine visit may not be related to another E&M service within the prior 7 days. So if you've seen a patient on Monday, as an example, in your office for, say, a conjunctival infection, if you discuss that, if that patient contacts you 3 days after that visit by telemedicine method, you can't bill for that telemedicine visit. It's kind of covered underneath that original E&M in-person visit that you did. Also, you may only bill for a service related to a specific problem in a 7-day period. So think of it this way. You have a 7-day global period after an in-face E&M service or after a telemedicine service where you may not be able to bill for another telemedicine visit during that 7-day period if it's related to the same problem. Also, if the patient contacts you with a problem and you decide in discussion with that patient or communication through text messages or email that you really need to see that patient face to face, and that appointment is scheduled within 24 hours of that discussion or the soonest appointment availability time, then you cannot bill for the telemedicine service. And also, these services may not be related to any surgical procedure that's still within their global post-op period. So you can't use them, say if a patient's had cataract surgery, you may not use these to do post-op care and bill for them. The most important thing is that the telemedicine visit is only conducted by the physician or other qualified healthcare provider. Calls to your staff that your staff handles are not able to be billed as a telemedicine visit in most cases. So if a patient calls your office and a staff member takes the call and The patient says, I've got a sty again. I've had these for years. What can I do for this? And your staff members says, I'll use just hot compresses or something along that line. Then that is something that's not a billable encounter with your staff member and the patient. So let's talk about the synchronous telemedicine platforms. The HIPAA compliant platforms that are available, and these are only some examples, are iCare Live, VC, and Zoom for Healthcare. Non-HIPAA compliant platforms which may now be used under the emergency orders are FaceTime and Skype or Zoom, anything along that line. One of the important things to remember about these telemedicine visits is that several of them are time-based. So the more time you spend taking care of a patient's problem, the higher code that you may use. And then we'll discuss the specifics of time as we discuss the specific codes later. But let me give you an idea of what's included in that time. And this is just doctor time. It is not staff time. It has to be doctor generated time. So if you need to, the time that you take to review the initial inquiry from the patient, and if you need to look at any patient records or data before you actually speak to the patient about the problem that they've contacted you about, that's part of the time. The time that you spend actually talking to or interacting with a patient to discuss the problem and to evaluate things, that's added to the time. Development of the management plan, say after you've gotten off the phone or off the Skype with a patient, you take time to put things together and you generate a prescription or order some tests for the patient. That's included. If you talk to the patient 2 or 3 days after that initial contact about the same problem, that's added to it. So for those codes that do require a time element in them, I would tell you that I would wait to see how much time you have within that 7-day global period after the initial telemedicine visit before you actually build the code that you want. Because like I said, once you build that one code, that's it. You're stuck with it. So now another thing that you need to know is what do you have to put in the patient record? Because it all has to be there. I know that the OIG has said it's going to be very lenient on any audits of records for these types of visits, but these are things that need to be there, and you should be doing most of this anyway as far as normal exams. There's just a few extra things that you have to put in there. First of all, you need to say in the record that the patient has given you verbal consent for the visit and to bill it to their insurance company, that they are an established patient, and that the patient is done, if the patient visit is done using a non-HIPAA compliant platform, if that's applicable. Next, you need to move on to exam elements. First of all, you need to record the chief complaint and the history of present illness to determine medical necessity or show medical necessity in their medical record. That's no different than what you do for any other in-office medical eye care visit. You can't bill it to a Medicare carrier or any other insurance company as a medical visit unless you've shown medical necessity for that visit. Next thing you need to do, just like in any other exam, is record the exam elements in your findings. And then you make any notes if there's any images that have been sent to you by the patient, or make notes about some maybe video that you've looked at as the patient is communicating with you on using a synchronous method, such as FaceTime. Make notes about what you thought of those images. Then you have to come up with your diagnosis, and then you have your plan with notes about any treatment or prescriptions, and make a note as to what pharmacy you sent the prescription to for the patient. Other record keeping things, and this is where the time element comes in. Note the time the consult began and ended, and also note the time of other elements of that cumulative time we were talking about a few slides ago for billing purposes. So if you see a patient today for a telemedicine visit, and say your total time is 10 minutes, and then you check in with them the next day or a couple days later, and your total time there is 5 minutes, and that's it. Everything's done. After that, your total time vested in that telemedicine visit is 15 minutes. And then you can use, if you use a time-based code, then you can bill that accordingly. Now also, you need to probably make a note in the file that the televisit is not related to a face-to-face E&M visit or any other televisit within the 7 days prior to the contact with the patient. We need to record your CPT and ICD-10 codes. And also, under the emergency regulations, we're allowed to waive any copays or payments from secondary payers for the patient's services. If you do that, go ahead and make a note that you did waive those copays, etc. Under normal circumstances, just like any other day, you were not allowed to waive patient copays or secondary payments from secondary payers. So let's move on now and let's talk about the specific codes sets that are available for telemedicine. The first couple of sets we're going to talk about are for synchronous communication. Remember, that's the iCare Live, FaceTime, Skype, Zoom at this point in time, those communications. If you look in your CPT book, at the very back, there's an Appendix P that has a list of all of the codes which may be used for the synchronous communication methods. Most of them don't apply for optometrists to use. So what I've done here is to list the 6 that are most applicable. Remember, here that under normal circumstances, the 99, 202, 203, and 204 would not be applicable because you can only do these for established patients under normal times. But we have an exception for that now. And of course, you have the 99, 212, 213, and 214. I've left out the 201, 211, and the 205, and the 215 codes on purpose because they're not anything that you should worry about billing. And as you'll see in a moment, I have my doubts as to whether or not the level 4 codes could even be met by you in this. There's 3 other codes that are only to be used with synchronous communication, and that's the 99421, 422, and 423. They are not currently listed in Appendix P. So let's talk about the 992XX codes for telemedicine. First of all, as I mentioned before, you have to use the synchronous type of communication. And just some suggestions. Unless it's for an extreme emergency, only utilize this for established patients. Again, we have an exception now, but I'd be very careful about seeing brand new patients for any telemedicine visits, especially now. Number 2, I would really highly suggest that you don't even try to bill for a level 4 code. So don't use the 99204 or the 99214 because you can't fulfill the number of exam elements required for these types of examinations. And those stipulations as far as exam elements for the various levels of E&M code are still in effect. They have not been waived. As far as your HPI goes, I always tell everybody that I talk to, always do 4 elements of an HPI, and that's easy to do. You know, what's the problem? My right eye hurts. My eye hurts. Which eye is it? How long is this been bothering you? How's your vision? Can you do anything to make it feel better? Have you been using some drops or have you flushed the eye? That's easy to get 4 elements, and that way you're always sure that the history portion of these visits is taken care of and they're covered. Let's talk about the specifics here. Now, you'll see on some of these codes I've listed fees. These are the current Medicare approved fees for Virginia. Now, for the 99212, for your history, you have an HPI of 1 to 3 elements is all you need. As I said, I would suggest you do 4. review systems, you don't need to do any of that. Personal, family, social history, you don't need to do any of that. For your exam portion, you only need to do 2 or more elements. Easy to do. Medical decision making, straightforward. Easy to do with any problem a patient would contact you with. The 99213 requirements. History, again, your HPI is only 1 to 3 elements. Review of systems changes here in that you have to do a problem pertinent review of systems. So you could just make a comment about the ocular system, and that takes care of it, or if a patient happens to be diabetic, make a note of that, and or hypertensive, same thing. Personal, family, and social history, don't have to do any of that. Exam, on this one, you have to do 6 or more elements, and I'll give you some examples of how I think you can probably meet that requirement in a moment. And then for medical decision making, again, your criteria there is low, and again, very easy to meet with any problem the patient would contact you with. Let's talk about some possible exam elements. Let's talk about visual acuity. Now, of course, we're all used to measuring 20/20 or so acuity in the exam room, but we also have a use of gross test of acuity. So as an example, you might ask the patient, do you have a clock across the room from you? Do you have the cable box across the room from you? And it's yeah, it's 10 feet away. Have them cover one eye and say, can you see the letters and numbers on the cable box or clock that's there? And they'll give you an answer. Then they cover the other eye, and they may say, no, it's all blurred now, I can't see it well, and that's the eye that's bothering them. Write that down. Tell them what you had them use to check the acuity, and that would easily take care of that element as far as I'm concerned. Ocular motility is easy. Remember, you're using the synchronous communication method, so you've got a live patient sending you pictures, and you can simply have the patient hold their phone away from them and have them move their eyes in the different meridians, and takes care of ocular motility. The conjunctiva, bulbar and palpebral. Have the patient lift up their eyelids or pull their eyelids down while they're close to the camera that they're using on their end. Easy to do. Ocular agnexa. Have the patient show you what their face looks like around the eye or eyes that are involved. You may pick up some signs of preseptal cellulitis or something along that line. Neuro-oriented to person, time, and place. Easy to ascertain as you're dealing with a patient on the phone. Psychiatric. What's their mood and affect? Are they upset? Are they agitated? Are they calm? Write that down. Pupils and iris is tough to do. Of course, you can't do your normal Perla test, but you can probably just check for any signs of anisocoria and check for iris color and condition if you've got a decent image that you can use with the patient. Let's move on to the next codes that you can use. And again, this has to be done with the synchronous communication such as Facebook or Skype. And these are the 9942X codes. And these are time-based codes. So remember what we were talking about earlier. You have the cumulative time for up to 7 days. So if you communicate with a patient a few times over the course of that 7-day period after the initial telemedicine consult, just add that time up over the period of days, and then you bill the appropriate time code after you have added the time up. And I'll give you an example of this as we go along. The 99421 is 5 to 10 minutes, the 99422 is 11 to 20 minutes, and the 99423 is 21 or more minutes. And again, the fees here are the current Medicare reimbursement fees for Virginia. Now let's go on to the non-synchronous or asynchronous type of codes that you can use for these virtual visits or telemedicine visits. we have two G codes, and these are commonly known as virtual check-in codes. So the G2010 would be something where a patient sends you a video or a picture of their eye. Again, this is the store and forward method. And they send it to you by email or text message. And then you look at it with an interpretation, and then you contact the patient within 24 hours, and you have determined what the problem is and give them a plan to take care of it, and you're done. That's a very short visit. The G2012, again, you've got a brief visit, 5 to 10 minutes, where you're communicating with an asynchronous method, and you basically kind of discuss the problem to see if a face-to-face visit is needed. If during that 5 to 10 minute conversation you determine that there's no need for the patient to be seen in person, and you can perhaps give them a treatment plan, then you would build this code. Remember now, in these codes here, and these might be where they're more applicable, once you talk to that patient, if you determine that you can't take care of their problem just by dealing with this on a telemedicine basis, and you do need to see them face to face within that 24 hours of the soonest available appointment, you can't bill these codes. All you can do is to see them the next day, and then you bill for the appropriate in-person E&M code. Let's move on to interprofessional e-consult codes. And there's two of these that can be used. One is used by the initiating doctor, and one is used by the doctor who's being consulted for the patient problem. So if you're the consulting doctor, you've probably been contacted by telephone or some other means by the questioning doctor, and you look at the images and so forth, and you spend 5 or more minutes in consultative time, you bill 99451. Now, for the doctor who's asking for the consult, if you communicate with the doctor that you're asking for help from, you can use the 99452, and this is for up to 30 minutes of your time that is used for that. Let's talk about now submitting these codes for payment. And remember that you've gotten in the very beginning of your visit with a patient, you have received verbal consent from them to bill their insurance company for these visits, and also verbal consent that if there's any copays, that they are responsible for those, unless under the emergency regulations that are in effect now, you decided to waive any copays for the patients. So let's talk about submitting these codes and what you need to do. For the 992XX codes, you need to use a modifier 95, and the place of service is 02. For the 99421X codes, again, you use modifier 95, and the place of service is 02. The 95 modifier refers to the fact that these visits were done with the use of the synchronous type of communication method, iCare Live, FaceTime, Zoom, anything along that line. And the 02 is the place of service code used for telemedicine codes. Now for the G codes, the G2010 and 2012, there's no 95 modifier because these are not done using the synchronous communication method. But they are telemedicine visits, so you just use place of service as 02. For the 99451 and 99452, place of service is you're in your office asking or communicating with the doctor you're consulting with, so your place of service is going to be 11 for this type of visit. Let's do some examples of the codes that you can bill, and this will also include examples of HICFA forms that are filled out for you. So here's an example for a 992XX code. Patient calls with a problem and you establish contact through FaceTime. So this is now using the synchronous communication method. You diagnose acute atopic conjunctivitis OU, and after doing the chief complaint, HPI, and the two exam elements, you recommend a course of treatment for the patient, and of course you document all of that. So when you bill this on your ICFA form, your diagnosis code is H1013, and you put your date of service down. Your place of service is 02, and for this one, since you've done two exam elements, is 99212 visit, 95 for the synchronous communication, and A just as a pointer back to this diagnosis code. Next one is patient calls and you establish contact through Skype. Again, you're using the synchronous type of communication. So after you do your chief complaint and HPI, you're able to do or need to do 6 exam elements, determine the diagnosis of mucopurulent conjunctivitis OD. Again, so for this one, since you've done 6 exam elements, you're able to use the 99213 code. Your diagnosis code is H10.021. Place of service is 2. 99213 code. Modifier 95, and A, again going back to your diagnosis ICD-10 code. Let's talk about an example for the 9942X codes. The patient calls you to establish contact through FaceTime. So again, you're using the synchronous communication method, and you diagnose mucopurulent conjunctivitis OU, and you spend 10 minutes on the patient call and call in the pharmacy the prescription for that patient. But then you contact the patient for 2 more times over the following 5 days just to check in to see how they're doing. And so the total time for those other 2 visits is 15 minutes. So you have an initial 10-minute visit, and then you have 2 other visits that are a total of 15 minutes. So you have a grand total of 25 minutes that you've used for that patient's problem. So since the 99423 is 21 or more minutes, that's the code that you would use. And you again, your ICD-10 code is the H10.023 because it's both eyes now. Place of service is 02, the 95 for the synchronous communication, and the 99423 is there for the total amount. Let's move to the example of a G2010. Patient sends you a picture on your cell phone through email or text. So now we're dealing with an asynchronous communication method. You look at the picture, it looks like the patient has a subconjunctival hemorrhage. Call the patient back, and after a few questions, you determine that that is correct. So what you would do is you would bill the H11.31 as the diagnosis. Here's your CPT is G2010. Ignore the slash mark that's in the modifiers. That's just an artifact. And the diagnosis pointer goes back to A. Since this is not a live webinar, if you have any questions, please email me at tcheezum@cox.net. I have my cell phone number there as well, but if you communicate by email, that will probably be faster for you. Also, I would like to thank Dr. Sarah Sheets for her help in putting this together. Sarah does search engine optimization and online communication for offices, and she works through drthrivemedia.com. So again, thank you, Sarah, for your help. It's greatly appreciated.